Before starting, have your patient seated upright with their back exposed. Have their arms resting comfortably on a table. Examining the patient, there is dullness to percussion extending to the mid-zone of the right lung. The presence of fluid can be confirmed with ultrasound, and commonly now a pleural tap is done with ultrasound guidance. Ultrasound can be used either to guide the needle in real time or to identify the location of fluid beforehand, as shown here. Here the probe is held in the intercostal space, as ultrasound will not travel through rib. In this image, black fluid is seen at the top. Mark the point where you'll perform the tap. This can be done using the blunt end of a syringe or needle. Assemble your equipment. On a sterile field, you can place a cleaning stick, gauze, sterile acoustic gel, needles and syringes. Ideally, this procedure should be performed using a sterile gown and sterile gloves. Clean the area carefully with your cleaning stick. You may wish to place an incontinence or Inco pad underneath to catch any excess cleaning fluid. Check the local anaesthetic with a colleague and draw it up. First warm the patient, then infiltrate the local as a bleb under the skin, and then infiltrate the deeper layers, making sure to stay above the rib below. You will draw back fluid into the needle as you aspirate when you enter the pleural space. The tap is then performed using a larger 50 ml syringe and green needle. Advance the needle, keeping it straight and in line with the rib. Draw back and collect the fluid. In this case, it appears slightly turbid, but is not frankly purulent. Remove the needle and apply pressure with some gauze. To finish, place a simple dressing and send the samples to the lab. Typically, these will be to microbiology, for microscopy, culture and sensitivity, for cytology, and to biochemistry for protein, LDH, and glucose. pH can be measured with the blood gas machine.